እሺ ቅዱሳን እንኳን በሰላም መጣችሁ። I'm so happy to see you around. እና you know the objective of this presentation. So we are exploring something new, right? So I mean, traditionally medicine is being taught at bedsides. We call it bedside teaching. So we named this initiative website, you know. At least we are using the web. We are not at the patient's website. So I mean bedside, and most of the cases which are going to be presented here would be ideal cases. They are not, entirely hypothetical. So most of the patients are true patients. We do change the name, the age, and all that. Patient identifiers are not going to be included in this presentation. So for today, what I'm thinking is we are going to give you a surprise case. I will tell you that you've complained, and you guys are supposed to be participating actively in telling me differential diagnoses and things like that. Just to give an idea to the group, to the organizing team and everybody. So I will be the patient. So the way we do it is like, I will tell you the chief complaint, why I am, at the emergency department in Black Lion Hospital. And then you have to go ahead and ask relevant questions to construct your HPI. Okay, so I'm not going to tell you the HPI. You guys should ask the question and I will give you the answer as a patient. So I will be pretending as if I am the patient as well. And then as we go along, we talk about differential, we talk about investigations and things like that. So you know the format, right? So we will follow the standard format for a bedside teaching. So without further taking much time, I'll straight go ahead and start the presentation. I'll share my slides. I have prepared a slide to make life easier. So the name entails, it's a website that Dr.FSH, Team Clinical Year Demystified. So we own this project as a team. We have about 15 or 16 members who are working on this project. Everybody who is interested can contact Zex, Gamacho, and others, and then, we are more than happy to include you guys. And I would be more than happy to see students from all the medical schools from all over Ethiopia. We are not focusing only on those medical schools which are located in Addis. Okay, so both private as well as government medical school students can participate in this project. So, oh my God, so I'm experiencing this severe bad chest pain, which started about 20 minutes ago. And I'm at the emergency department in Black Line. So go ahead and give me a differential diagnosis. Let's assume you guys are the interns in Black Line. So I am a 61-year-old, I think I am 61, yeah, 62-year-old male patient, as you see. And I am complaining of severe chest pain, which lasted for 20 minutes. I am in the emergency department. Give me differential diagnoses. And the location is substernal. Severe substernal chest pain, 20 minutes duration. Differential. How do I see the message if somebody is responding to the chat box, Brooke?
ወደ ዙም መመለስ ነው and then chat የሚል አለ ከስር ከፓርቲሲፓንትስ አጠገብ
Okay, I see that. Okay, just hold on guys, I have missed. Can you read them out to me, Zex?
yes
Whatever
definitely
they're writing. Okay.
RY MI ብላለች ወይም ብሏል
MI, okay.
pulmonary embolism acute MI
okay.
angina pericarditis
If I slow down, angina,
pericarditis yeah
okay, what else?
myocarditis
okay.
aortic aneurysm rupture
Aortic aneurysmal rupture.
acute coronary syndrome MI
SAS, okay. Yeah, MI, SAS, angina. They are almost the same, right? So MI, SES, angina.
Aortic dissection.
Okay, aortic. All right. Aortic dissection.
Pancreatitis.
Huh?
Pancreatitis.
Pancreatitis. Okay. Uh-huh.
Okay. Dr. Fitsum, I think was about to say
We
something.
can, I think we must have a systematic approach for a complaint of chest pain because the cause
No,
can
that's
be.
fine. That's fine, Fisome. That's fine. They can call anything. Don't limit them. Okay, they can say anything they want. Okay, we'll talk about it later. I'll come to it.
Okay. Okay.
Give me a differential diagnosis. It could be anything. You can say like, you know, leg trauma. I don't mind. So whoever has given the differential diagnosis would be, you know, defending their differential later on. Okay, we'll ask them why they're mentioning these things. I'm just pointing them down right now. Anything else?
Costochondritis.
Costochondritis.
Esophageal rupture.
Esophageal rupture.
GERD.
GERD.
Someone from psychiatry. Panic attack.
Panic attack. Psychiatry attachment syndrome. Okay. Panic attack. Those are good considerations, though, actually. I like it. Anything else, guys? Anything else?
Pneumothorax.
Okay. Anything else? Literacy. Anything else? Refracture. Why refracture, man? Spontaneous refracture. Okay, let's keep it. We'll keep that. That's fine. Pulmonary hypertension. What else? Zex, are you there?
Yes.
All right. Am I missing anything?
Nope. There.
All right. Anything else?
Nothing more is coming.
Nothing more. Okay, so let's deal with this one. So, okay, so I am going to pause here and I'm going to invite you guys to dwell a little bit and give me the rationale why you guys are thinking this way. So MISS angina, whoever has said one of this, can you elaborate on this one? Why do you consider MISS angina for somebody 62 years old male patient with substernal chest pain of 20 minutes duration? So why did this differential diagnosis cross your mind? Just say something, you know, just participate, justify why you are thinking this way. And your participation has to be really, you know, try to be as engaged as possible and not tolo mellisu. That way we can save time, we can discuss more, and it's not going to be boring for you guys, okay? So this is my approach. This is the way I do it. So there is a chief complaint, somebody thinks something, you know, the whole idea is when somebody tells you a chief complaint, a certain list of disease processes would come to your mind, and then your job would be to go ahead and elaborate, right? So why did you think of MISCS or angina? Because they are under the same umbrella. That's why I'm grouping them together. Go ahead, please, guys.
Okay. Hello.
Yes, go ahead, please.
I said STS and angina because those generally ischemic heart disease is common in older age, and the site where the patient feel the pain is also a bit supportive for my differentials. So this is why I said.
Excellent. I love it. What's your name? I love your approach. So Tasfasione is a very beautiful consideration because you consider a risk factor. This patient is a male, he's high risk to have like, myocardial infarction, angina, or acute coronary syndrome. This is a male patient as well, age is 62. So, at least age and sex put this patient under like, high risk to develop this one. And the characteristic of the pain, acute onset, short duration, substernal chest pain. What else could it be, So, and considering risk factor and presentation, MISS angina, they are like, amongst the differential to be on top of our differential diagnosis. Excellent. What about P? Who said PE, pulmonary embolism? Why do you think of PE in this patient? Hello? Go ahead, please. It shouldn't be the person who said it if they cannot really respond. I wish they can defend their differential diagnosis, but if they can't participate, anybody who agrees on this differential diagnosis should say something about it. If you also disagree, you can say, oh, I don't think PE should be top on the differential diagnosis for this reason, or you should argue that PE should be on the top of a differential diagnosis for some reason, okay? So you can argue for, or you can argue against, okay? So you can do that. Please try to do that.
You can.
Hello.
Hello, go ahead, Arwai. Go ahead, please.
So I think that PE is a good differential because number one, the acuteness of the symptom is one thing, and maybe the clot could have caused the pain due to poor blood perfusion, and considering the patient is a male and he's 61, maybe he's not that much active, and he has maybe risk factors, maybe additional that we're not aware of currently.
Yeah, we are not sure about risk factors, so we'll wait until we go into the HPI and all that. But like you said, PE is an acute illness. Sometimes it can be associated with chest pain. But the only problem and caveat is PE doesn't usually give you substernal chest pain. For example, if somebody says, oh, I have left-sided chest pain, right-sided chest pain, which is acute, pleuritic type, you can consider like a possibility of PE with pulmonary infection, because PE, pulmonary embolism, with associated complication like pulmonary infarction can present with chest pain, characteristically pleuritic type of chest pain, okay? So we cannot really argue for or argue against, but at least PE is a common differential diagnosis and is one of the killers we want to consider about. At least we are thinking about it. I don't really think this is a high probability in this particular patient based on this history only, but like at least I will keep it in my differential diagnosis, because if I miss it, it will kill the patient or it compromises the patient big time, okay? Angina, the same thing, because MISS angina, they are under the same category. What about pericarditis, guys? So keep on thinking as we scroll down, think about the differentials you see displayed. So tell me whether they should be kept in the differential diagnosis or should be kicked out, okay? Go ahead, guys. Pericarditis. And you can talk about pericarditis and myocarditis together. Don't be scared, by the way. Those people who are courageous enough to participate, they are always the winners, by the way. They may give a wrong answer, that doesn't matter. A wrong answer is as good as a good answer for me. I don't want you to have a wrong impression in real patient, but in this session, you can think the way you want. And tell us the thought process. That's where we are working on. How are you thinking? What's your thought process? What is your rationale in mentioning these differential diagnoses? Okay. So pericarditis, myocarditis. Somebody please volunteer.
Hello,
Don't
someone? Can
yes,
you hear
it's
us?
someone. Yes, yes.
Yes, this is Agatha talking.
Okay, go ahead.
We said myocarditis. and pericarditis because of the location, substernal location መሆኑ, and added with the patient's demographic.
Yes, I mean, like, age is not as such, like, known risk factor for these conditions, right? Pericarditis can happen in any patient, myocarditis can happen in any patient. But like you said,
Yes.
especially for pericarditis, the location could be typical, substernal chest pain. But yeah, it's at least you have to consider myocarditis, pericarditis, at least at this point, until you get the chance to go to the HCPI and elaborate on the pain further to either support your differential diagnosis or to help you exclude it from the differential diagnosis. So that means it still survives to be kept in the list, right? Pericarditis, myocarditis, we still keep them. We will see if they are going to, like, stay in the differential later on, okay? Aortic aneurysmal rupture and aortic dissection. Oh, Zaka, go ahead, please, if you want to say something.
To add on that, myocarditis, if we have another complaint, for example, if there was viral infection or history of upper respiratory tract infection, we think myocarditis. But for pericarditis, for our epidemiology in our country, TB is the most common complaint. So if we have associated with that in the HPI, it could help us in this diagnosis.
Excellent. So both of you are correct. You are in the right direction. Your differential diagnosis survives, staying in the list for now. But we are not sure whether it is going to stay in the differential diagnosis or not. That we will see in the next slides, okay? So the whole point of giving a differential diagnosis just based on differential on chief complaints is, list of problems crosses your mind. You keep them, you think about them. When you think about it, you ask questions related to it. Just like Mary said, did you have any recent history of like upper respiratory tract infections? Were you diagnosed with upper respiratory tract infections in the past week or so? These kind of questions would come later on. But for now, you don't have that information. So what you know is substernal chest pain, 20 minutes duration. That's it. So your argument is going to be only based on that information, okay? So if this happens, that is going to come in the next slide, not right now, okay? So aortic aneurysmal rupture, aortic dissection. Why do you want to add this as a differential diagnosis at this point? Shall we keep them or shall we erase them from the list?
Hello.
Yes, go ahead, please.
So aortic dissection, right, is the differential that we're discussing right now?
Aortic dissection and aortic aneurysmal rupture, both.
So I think the acuteness of this presentation sort of makes us think of it. And yeah, that's more of what got my attention, the acuteness of the symptom.
Yes, the acuteness and the location of the pain also, right? So chest pain, substernal chest pain, sudden onset. So it could be aortic dissection, you never know, but there are special characteristics of acute, how patients with acute aortic, how patients with aortic dissection or aortic aneurysmal rupture present to you. So the only thing against aortic aneurysmal rupture is what? Based on the presentation. So I am the patient, I am sitting in the emergency department at Black Line. You are the intern, you came in, and I'm telling you, oh, doc, I came with a chest pain 20 minutes ago. Which started 20 minutes ago. Do you still want to keep aortic aneurysmal rupture?
Probably not, because the aortic rupture would have caused you not to even be able to speak. You would have been collapsed and probably came with an ambulance.
I love it. Excellent. Imagine, let's say aorta which ruptures. So I am dead or I am in bad shape. Most probably, I wouldn't be a stable patient sitting in the emergency department bragging about my presenting complaint, right? So aortic aneurysmal rupture could be devastating. So the patient could be unstable, hemodynamically unstable, or the patient dies on the spot. Those only few lucky people make it to the hospital for that matter with aortic aneurysmal rupture. They bleed. 2 days, all right? So I love your point. So most probably we'll kick out aortic aneurysmal rupture from the list and we'll keep aortic dissection for now. It survived, okay? What about pancreatitis?
Hello, everyone. I hope my voice is audible.
Yes, Bethlehem, go ahead, please.
So the reason I considered pancreatitis, particularly acute pancreatitis in this patient, was the fact that it is more of a substernal pain. So substernal, I'm assuming substernal is equal to epigastric type of area. So that's why I considered it,
not.
but I'm not sure.
It is not, Betty, because like, substernal means it's just behind your sternum in the chest. And epigastric means it is below, it's the upper part of your abdomen, below the thoracic cage, right? So epigastric pain is something else. Substernal chest pain is something else. They are not anatomically related, okay? So would a patient with pancreatitis present with substernal chest pain? You can ask yourself, do you see, is it a common presenting symptom for patients with acute pancreatitis? That should be the question you should ask yourself.
Not
Obviously,
really.
it has to be acute, right? We have to be specific. So acute pancreatitis. Okay. So do you want to keep the acute pancreatitis differential at this point, or you want to kick it out?
I believe I would like to kick it out.
Yeah, kick it out. I mean, I don't think it's, I mean, like, it's very typical acute pancreatitis patients. They do present with abdominal pain, and that pain radiates to the back most of the time. I know I didn't give you the privilege to ask further questions, whether it's radiating or not. But like at this point, it is less likely because those two anatomic locations are different. Yeah. And I don't recall any patient over the past how many years. I have never seen a patient with acute pancreatitis presenting with substernal chest pain. Rather, there are other GI problems which may mimic, MI, right? So what are those? What about costochondritis? Okay, let's go as the list. Costochondritis, anterior chest pain, 20 minutes duration. Shall we keep it? Only few people are participating. There are 25 participants. If you guys are enjoying this presentation, please participate, because those who are actively engaging all the time are the ones who are benefiting the most. Believe me, don't be passive participants. Be an active participant. Demonstrate your skill. Demonstrate your thought process. Challenge me, I will challenge you. Okay, that's how you grow. This is a communication between physicians as well, because this is how we dialogue between specialties. Sometimes we may have a case conference between different specialties. One attending thinks something, I think the other way. We argue, and we argue not to fight, but just based on science and logic and common sense and evidence, actually. Okay, so start practicing that now. You will be a great physician tomorrow. Okay, please participate. Like I said, a wrong answer is as equal as right answer for me at this junction. Okay, so participate, please. Zex, by the way, in the future, we have to come up with a certain strategy to increase engagement. People like prizes and all that. So we can make a note of those people who are actively engaging. So whoever has answered the questions the maximum time, we will give something, a surprise gift or something like that. What do you think, Zex?
I agree. I completely agree.
Exactly. Go ahead. So probably the prize might start today. Who knows? Arroy is ready to answer already. You have scored 2 so far. This is going to be your third participation. Go ahead. I am happy.
So costochondritis, I think it's an okay differential to start with, because of the location of the pain, because it's
Yeah.
substernal,
Yeah.
close to the ribs, so the inflammation could be there. But would it be this acute is a little bit of a question, but at least the location sort of, yeah.
I agree with you. Most probably, even if you still want to keep it as a part of a differential diagnosis, it's not going to sit up here. We'll definitely take care out of this position, at least cut it out, and I'll put it down, as least likely differential diagnosis, probably, who knows, you know what I mean? So, I mean, it's substernal most of the time. Costochondral, as the name entails, it happens at the junction between the ribs and the cartilage, right? So that's maybe paramedian kind of stuff. So the acuteness and everything, it wouldn't be really as acute as this patient's presentation, prompting the patient to come to the emergency department right away. Less likely, right? So, but we keep it down there. All right. Any other esophageal rupture, GERD? Are there still possibilities?
I would actually consider GERD a possibility.
Oh, Kadus has started talking, so Kadus, go ahead.
I consider esophageal rupture, especially for HIV syndrome. They usually have severe retrosternal pain that's acute, and it's fairly common in males. And the presentation of acute retrosternal chest pain could explain esophageal rupture, but further characterization of the pain and associated risk factor.
Shall I take it up or shall I carry it down, Kadus? I love your idea. I love your argument. Esophageal rupture. Up?
Yeah.
You are smart because I already started doing that. So maybe esophageal rupture could be, top in the differential diagnosis based on the limited information we have. Acute onset substernal chest pain. It could be spontaneous esophageal rupture. We don't know the circumstances. We will see later on. So we may kick it out, we may keep it, we may keep it up, we may keep it down. Okay. Okay. But what about GERD? Gastroesophageal reflux disease?
Okay, actually, I picked that one solely based off of epidemiological reasons. It's actually the most common cause of chest pain, but normally I wouldn't really consider it that early. But first I would have to rule out the serious causes like MI and angina. So if perhaps ECG and biomarkers are negative, then maybe GERD would be a possible differential.
Derek, I love your argument. I love it. It's in the differential diagnosis. It's a substernal chest pain. So gastroesophageal reflux disease actually presents with heartburn, and heartburn is described as a substernal chest pain. So it stays in the differential diagnosis. Like you said, it may not be as acute as, this patient's presentation. We keep it in the differential diagnosis. We will see if it is going to stay in the differential as part of the differential diagnosis. Panic attack. Panic attack. Panic attack.
Panic attack may be interesting, a very interesting differential, because usually, like some people say, it's like they get shortness of breath and they feel like they are having a heart attack, and that sort of adds to the panic as well. So the acuteness of it and the location, once again, really supports this. So yeah.
Excellent. So I mean, like, panic attack is a possibility because people with panic attack, the characterization, especially those of you who have been through, psychiatry, most of the time, these people with panic, they feel as if like, they're about to die. They may have some degree of shortness of breath. They may have like an acute chest pain, chest tightness and all that. So they may feel they are having a heart attack and they may come to you. So panic attack is a very good differential diagnosis. Is it common in the elderly male? That's something which we can debate about, but like, panic attack is a good differential diagnosis. If it was a young lady, female, whatever, with certain risk factors and a higher history of panic attacks and all that, or even if this is a first presentation, panic attack can be a potential differential diagnosis. What about pneumothorax and pleurisy?
Wait, doctor, can we consider the patient's job as a risk factor for panic attacks? He is the CEO of a company, right?
Did I say he is a CEO?
Yes.
I never said that. Did I?
Yes, personal identification, yes.
No, I didn't go to personal identification. I didn't even go there. Don't cheat.
No? Okay.
Don't cheat.
Okay, I thought I saw that.
Derek, stop looking down. You are supposed to see only this slide. Don't go this, don't see this side. How can I blind that? Zex, how can we blind this information? These guys are interesting.
Better to zoom out the slide.
That would limit many things for me. You know what I mean? If I completely zoom it out, I cannot type and all that. You know what I mean? I want to type because, like, in the future, somebody who missed this seminar would have the opportunity to see what we have been discussing, what we have deleted, what we have kept, and everything. That's the main problem. Okay. So the solution is don't look. Okay. Don't look. Don't look anything more than, don't look into any information more than I'm telling you. Okay. That makes it interesting and challenging for you guys. If you look ahead, then you spoil the whole surprise of this presentation and it misses its point. Okay? I want to challenge you. All right. So what about pneumothorax and pleurisy? That's fast. You can go ahead. You don't have to raise your hand. You just step in, say something.
Okay, just to add on the panic attack, as it obviously it's better to consider, but as it is a psychiatric disorder and the diagnosis of exclusion, I think it has to be the last, because as it is diagnosis of exclusion, we may not go further thinking it. So better to drop it down.
Beautiful. I'm just taking your word. I'm taking it down. It's a diagnosis by exclusion. We have to work hard to exclude the deadly, most important differential diagnoses, right? So that's what we did right now. Beautiful insight. Go ahead, pleurisy and pneumothorax. Whoever wants to speak.
Good afternoon. So
Hello.
pneumothorax is a good differential to consider, since if you don't manage it timely and accordingly, it could lead to fatal outcomes. So patients usually present with acute severe chest pain and shortness of breath, and it's a clinical diagnosis. So it's a good differential to consider, even if it's not the tension pneumothorax, spontaneous pneumothorax as well could cause this condition. So it's better to rule out these conditions and further dig out other differentials.
Excellent. Pneumothorax stays for now, at least. Like you said, it may present with chest pain, it may present with shortness of breath. It tends to be acute, whether it's like spontaneous trauma related. There is no trauma in this patient. Most probably it's going to be spontaneous pneumothorax. So it can stay for now, and we will see whether it's going to stay there or not. Pleurisy. So
Doctor,
we have to, yes, go ahead, please.
I started not ruled out aortic aneurysm as causing the patient not to even speak, as it's really dangerous and it's really acute. Shouldn't the same principle apply to pneumothorax, even though
No,
it's not tension?
yes, so I mean, let me clarify something. I was going to comment on that assertion actually. Oh, this disease is a killer, so we have to think about it. The acuity, the seriousness of the problem prompts you to think about it. But if it doesn't explain the presenting complaint, then you shouldn't necessarily think about it. So logically, if it is a completely ruptured aorta, so the patient wouldn't be really stable enough to sit down, wait for you, and tell you that I came with a chest pain 20 minutes duration, and the patient wouldn't be as stable at that one. That is the reason why I'm taking it out, because it may not go with the patient's presentation. Is it acute? Is it a killer? Yes, it is. I can think about it, but my mind has already worked on it and excluded it. The differential diagnosis. Yes, it is a killer. It's a potential, but I would say to myself, I don't think this is aortic rupture, because if it was, this patient's presentation may not be this way. But pneumothorax, the reason why I'm keeping pneumothorax is not because it's a killer or it's a potentially killer or anything like that. Pneumothorax can still be a differential diagnosis. The chest pain can be explained by a pneumothorax. Is it a pneumothorax? I'm not sure. We'll declare it. Okay. You get the point, the difference between the two?
Yes, sir.
All right, go ahead. Who wants to speak? That's what's on. Go ahead, please.
Zila, I have a question on pneumothorax line. I have a question. Obviously, a patient with pneumothorax may have chest pain, but do a patient with pneumothorax initially present with chest pain, rather than the chest pain, the patient may seek health care because of the shortness of breath, I think. So
exactly that you are going to
the chest.
The thing is, sometimes when somebody develops a sudden onset pneumothorax, their presenting complaint could be, like you said, shortness of breath, or it could be a simple chest pain. But what happens is, even the pneumothorax has, spectrum and its severity, right? It could be a small pneumothorax, it could be tension pneumothorax, or it could be a very significant pneumothorax, but not to the extent of tension. So the presenting complaint could be a chest pain, and patient may have shortness of breath, That question you are going to ask him as part of your HPI. That's why you cannot exclude it. But when you go ahead and further try to elaborate the pain and the circumstance, whether the presence of, whether there is a shortness of breath or not, that would help you to either keep it or exclude it, okay? So remember, we are just at the chief complaint right now. We didn't even take a full history. So you have to remember that, okay? Go ahead, Betalia.
Can I say something?
Yes,
Right
go
on the
ahead, of
point
course.
about the pneumothorax.
Uh-huh.
So we were given the fact that the patient is not a trauma patient. We are considering spontaneous pneumothorax, right? Again, epidemiologically, spontaneous pneumothorax would usually be common in young men who are smokers, because of the
Not
rupture
really.
of the pulmonary blip.
Not really.
Within that, okay.
Not really, Mary. Reason being, like, this patient may have something else. So I would argue, like, what if this patient has a cavitary lesion in his lung and he comes with water?
That's a possibility. Yes,
Yeah,
yes.
what if this patient has TB? What if this patient has necrotizing lung cancer?
Or
with
even
water?
COPD, common in his
What
age
if,
group.
yeah, COPD,
One
asthma,
cause spontaneous.
COPD,
True.
asthma. So they are all possibilities. Yeah. All right. So
Of course.
refracture.
For refracture, the primary complaint wouldn't have been the chest pain. Rather, the patient would actually present with the trauma, saying that actually it's chest pain, with a fractured rib የሚመጡት እንጂ primary chief complaint have a chest pain ብቻ አይሆንማ.
Yes, we don't have a clue, right? There is no clue. The patient didn't say I was involved in a road traffic accident. The patient didn't mention he had a fall down accident, or he didn't mention he had trauma to the chest. So we don't have any information to think of a refracture. So I wouldn't dare to think about refracture. So I kicked it out. Pulmonary hypertension. Is pulmonary hypertension an acute problem or a chronic problem?
It's a chronic problem.
Most probably it's a chronic problem. There must be an underlying process for somebody to develop pulmonary hypertension. So this is a patient who was apparently healthy 20 minutes ago. So this is less likely to be part of our differential diagnosis. Pulmonary hypertension is out. Costochondritis is low in the list. Panic attack is low in the list. So this is the approach I want you to learn. So the list when we started was longer. Now we kind of shaped it based on only this chief complaint. Now we'll go further and further dig. We will see which one to keep, which one to remove from the list again. Do you guys like it so far? Say yes or no in the chat box. If you don't like it, I will stop the presentation here. I'm joking.
I'm sorry, I have a question. So when it comes to the pneumothorax, would it present as a substernal chest pain?
Not really. It may not be. It may not be. That's a good point. Instead of having like, saying like, pneumothorax, we better say pneumomediastinum. Why do patients develop pneumomediastinum? Probably like, related to esophageal rupture. So you can say esophageal rupture, pneumomediastinum can be a differential diagnosis. Less likely, pneumothorax is less likely. Pleurisy is also less likely because pleurisy, there is lung in the anterior chest. So still pleurisy can happen in the anterior chest. So substernal signifies the patient is located centrally. It's anteriorly and central to the chest. So there are still possibilities. Pneumothorax, pleurisy, there are still a possibility. Is this patient really having pleurisy? Pneumothorax, we'll find out, in the next few minutes. Sounds good? Excellent, guys. So this is the way I want you to think about differentials and all that. So this is the personal information of this particular patient. So this patient, my name is Emin, my age is 62 years old, sex obvious, I am married, and my occupation, I am like, a company CEO. Why is occupation important to this patient, by the way? Why is occupation important, guys?
It would have been directly.
Go ahead. Go ahead.
Okay, so one thing I would be considering is most likely CEOs tend to they have a lot of stresses in their company, so they tend to neglect their health in general. So that's one thing I would consider.
They are busy, they don't have time, always it's a meeting, always it's something happening, crazy happening in their company, so no time. Maybe poor health seeking behavior. Okay, it's a good point, good consideration. Most important than that, in relation to his presentation and everything, remember your top differential diagnosis, it could be MI, it could be ACS, it could be angina. So is the patient's occupation being a company CEO somehow relevant in this case?
Yes, it would be relevant.
It would be
Given the fact
relevant.
that many CEOs would have a sedentary lifestyle. So if this patient had been an athlete, then we wouldn't have thought about AMI, right? Because they would have an active lifestyle, no?
Yeah, it can still happen, but less likely, right? It decreases the risk, but you cannot exclude, because we have seen many patients with active lifestyle coming with MIs. Okay, so that's not 100% guarantee, but like, you know, it reduces the risk, right? At least they are not high risk to develop that. So he's a company CEO. The other, he has a sedentary lifestyle. What else do company CEOs have as a risk factor other than being sedentary? Guys, think. What about stress? Is it a stressful job? Being a CEO, is it stressful? Hello? Are you guys with me?
Yes, it's very stressful.
Very stressful, right? Because we are dealing with many headaches, right? So some people are friendly, some people are a challenge. So your company may be heading towards bankruptcy, or maybe you are making a profit, or somebody who is better than you is opening a similar company next to your neighborhood. You know, it's a lot of stress going on. It's a very stressful job. So that's very important, okay? Because like, you know, especially with the patient's complaint, sudden onset substernal chest pain, only 20 minutes duration. The occupation is very important. So in the personal identification, the age of the patient, the sex of the patient, and the occupation, especially if it's related with high stress, then that's relevant. Okay. Ask me questions now. Okay, what questions do you want to ask me? Don't read the left side, please. Don't read the slide number 6 and 7. Just what questions do you want to ask me as a patient?
Doctor, I think you can reduce the left side. There's a if you were to you can like just move it a little bit to the right, like the right, the mouse, like a little bit to the right.
The mouse.
Yes.
Okay.
So you can
like this.
Yes.
Can you read now? ካሮት ስትበሉ ነው የምታድሩት ይባላል። ካሮት ትበላላችሁ ይባላል በደንብ።
እስኪ ዳሪክን ጠይቀው። ዳሪክ ምን ይላል?
My eyesight isn't that good.
So Darik ጠይቀው. Yes, he was the one reading, right? So Darik, are you able to read now?
No, my eyesight isn't that good.
Okay, good. All right. እሺ ጠይቁኝ አሁን ጥያቄ. What questions do you want to ask to this patient? You are the physician taking care of this patient in the ED.
What was the patient doing when the chest pain started?
I was just like, you know, having an argument with one of my colleagues 30 minutes ago, and I was just trying to calm myself in the office.
Progression.
Huh?
Progression, like sudden acute, then it starts to worsen now through time wastes?
No, I mean, it remained constant. I mean, it just started 20 minutes ago that, and it stays the same. It's not going away.
Yeah, I can know the radiation.
Yes, it has some radiation, doctor. It's just heading towards my left shoulder.
Character of the pain?
The character is like, you know, I feel as if there is some pressure in my chest. You know, it's very hard to express it, but I feel as if there is some sort of pressure in my chest.
Does it improve with position changes?
No, I mean, like I'm just sitting in my bench. It's not really related to my position when I'm standing, sitting. I'm trying to lay down a little bit on my couch, but it stays the same.
You take any medication?
Uh-huh. Remember the differential diagnoses we have been discussing, okay? So you have to ask questions related to all those differential diagnoses. I'm just giving you a hint. Go ahead, my friend. Sorry for the interruption.
No worries. What I asked is this exacerbated with breathing or with cough?
No, it's not as actually related with my breathing or coughing. Actually, I don't have a cough, doctor.
Did you have the same pathological disease before?
I mean, in the past, I mean, I keep on neglecting, but like, you know, over the past 6 months, sometimes I have a little bit of a chest pain and it just stays for a couple of minutes and it goes away. But not as severe as this one. This is something different, doctor.
Do you have diabetes or hypertension previously diagnosed?
You can ask me those questions later. Right now, focus on the HPI. That's past medical history. You can ask me later.
Okay. Do you have any
patient in the asylum actually? Patients wouldn't say that. Don't ask me now. Ask me HPI, not. Go ahead.
Do you have fever or diaphoresis or palpitation?
Yes, doctor, I had this really weird, very cold sweat. I have never experienced this kind of sweat in my life in the past, but I don't have fever.
Okay.
Have you been experiencing fatigue or weight loss?
No, not really. I was apparently okay. I mean, I was active, doctor. Like, you know, I think I'm healthy, but I never had any fatigue in the past.
Does the pain get worse with food, like for certain foods?
Not really. Like I told you, about 30 minutes ago, before the onset of my symptoms, it's going to be about 50 minutes from now. I had a little bit of a quarrel. I was in the office. I was not eating anything. I didn't eat. I mean, I had my breakfast early in the morning, but I don't think it has something to do with food because I didn't eat any food recently.
Does the patient have any autonomic symptoms like diaphoresis, palpitation?
Like I told, what is diaphoresis, doctor?
Sweating.
Sweating. So why did I ask you this question? Because sometimes when we are taking history, use layman terms. Don't use technical terminology, okay? What is diaphoresis, doctor? So avoid those technical terminologies, especially when you are taking history. So I do have a cold sweat, doctor, and it is very weird. I never had similar complaints in the past.
Do you smoke?
Doctor, why don't you ask me this as part of my social history? But okay, that's fine. If it is important, I will tell you now. I do smoke cigarettes, yes.
How many?
I do smoke one pack a day.
Okay.
Is there anything alleviating your pain?
Nothing. Like I told you, the past 6 months, I kept on having this pain coming and going. And most of the time that pain, you know, it comes with a little bit of exertion when I'm doing something. But when I take a break, it just goes away. But this one, it stays the same. Nothing is alleviating. I try to calm myself. I try to lie on my couch. It's not going away, doctor. And one of my friends, actually, I forgot something. And okay, that's fine. That will change my case being it. So I'm keeping my mouth shut. Go ahead. I was going to say something.
Doc?
Yes.
Have I missed the character of the pain? Was it asked?
Yes, they did. No, they didn't ask actually. Did you ask? A pressure like Vigallo. I said pressure like. Yes, somebody asked me the character. Yes, I said pressure like.
How long did you smoke for?
I'm in the past 30 years. I know, doctor, I shouldn't have done that.
One pack for 30 years? Every
yes,
day?
that's a lot, right?
Not. What about alcohol?
Alcohol, I do drink alcohol sometimes, just like, you know, when I'm hanging out with my friends. So I would say I am a social drinker.
Do you
Do
go
you
out
take as a
frequently?
recreational? Do you take as a recreational drugs other than alcohol and cigarettes?
No, doctor. No. I'm a Christian. I don't do that. Keep on asking. There are many differential diagnoses as you mentioned. If you miss the opportunity to ask those questions now, you cannot argue later whether to keep them or kick them out. Okay, remember.
Do you have recent history of travel?
No, I don't. I didn't have any travel. I mean, I'm very busy. So no, my vacation was a couple of years ago.
No, I am like plane travel, long distance travel, not kind of vacation.
Yeah, so intention I have never traveled. I mean, I stay locally, so no flight, no long hours of drive.
Okay.
I'm busy doctor.
Any history of heavy alcohol intake in repeated vomiting?
Tasfazion, you have to listen. So patients would get irritated. Doctor, how many times are you asking me these questions? Weren't you listening to me? So somebody might be aggressive on you. So I said I'm a social drinker. I drink once in a while with my friends. Not heavy, one beer or two beers in a month or something like that.
Did you have a history of trauma recently over the past 2 days?
No trauma. No. Mary, you have been talking about respiratory tract symptoms and all that, so you have to ask now. Otherwise, pericarditis, myocarditis would be very difficult for you to argue for or to argue against later on, And I'm giving you an example. So all those differential diagnoses you kept down there, so you have to really ask questions relevant to them, okay? Any more questions?
Was there any history of difficulty of swallowing or vomiting?
No vomiting, but I feel nauseated, doctor. So it just feels, I mean, like I feel nauseated, but I never vomited.
Saga is asking if you have had any recent upper respiratory tract infection symptoms like coughing, runny nose, sore throat.
No, I was okay. I mean, I was apparently okay. I was just fine. The problem started 20 minutes ago. Do you want me to display the HPI? Let's display the HPI. Central chest pain, pressure, you missed the severity, okay? So nobody asked me about severity. So when you are dealing with pain, you have to characterize the pain. You have to ask for the locations. So location, central chest pain. Pressure, that's the character, and severity has to be asked. So the severity is 9 out of 10. Because if a patient complains of 9 out of 10 chest pain, that means you don't have to wait until you diagnose the problem. You have to kill their pain. You have to give them pain medications, right? So that's very important. That's relevant. So you have to really ask for severity, and it's constant. You didn't ask him whether, actually I told you that it's constant. It stayed the same, right? So radiating, I told you it's radiating to the left shoulder, left arm. Worsens with activity in the past at least. No relieving factor, I told you. Nobody asked me about relieving factors, right? I just volunteered that information when I talked about the angina-like symptoms in the past. And the pain remains the same in all positions. Somebody have asked for that question. Associated symptoms, cold sweats, I have told you, you have asked about it, some shortness of breath. Nobody asked me about shortness of breath. How are you going to really defend your differential of pneumothorax, pneumomediastinum, pleurisy, whatever, if you don't ask for shortness of breath? Even for MI, it's really relevant. A patient with MI presenting with shortness of breath tells you something. Could it be something? I mean, could it be a major MI with heart failure? Acute heart failure. That's also a possibility. You have to think of acute heart failure in this patient, okay? So shortness of breath, feeling anxious, and I feel anxious, okay? I feel anxious because of the pain. I feel like I'm dying. So feeling anxious kind of make you suspect the possibility of panic attack, because patients with panic attack, they feel anxious, right? So, okay, more or less you have asked most of the questions. And I told you, I volunteered actually, nobody asked me whether I had similar incidences in the past or not, but I said I had history of intermittent chest pain in the past, staying up to 10 minutes, improves with rest, worsens with exercise. Has been experiencing these symptoms for the past 6 months. The current pain is worse and it's stayed constant. I have told you all this information, right? So HPI, feels nauseated, no vomiting, I have told you. Argued with his DPT 30 minutes before the onset of symptoms, I have told you. You didn't ask me about orthopnea, pain, or lower extremity swelling. Is it important?
Yes.
Is it important, guys?
Failure.
Yeah, it's very important, especially if you are concerned about possibility of heart failure. Always good to ask, be exhaustive actually. Sometimes pertinent negative answers are as important as pertinent positive informations, by the way, because that helps you to rule out any differential diagnosis. So you don't have to assume that only the positive informations are relevant to making a diagnosis. Actually, pertinent negative informations are also equally important. So no orthopnea, no PND, no lower extremity swelling. At least we are not dealing with a patient who had chronic heart failure, at least. Okay? Menu? Hello? Who was speaking? Are you guys with me? Oh, no, that's fine. Okay. No prior cardiac history. Okay. So except that I had those pains coming and going, relieved by rest and worsened by exercise. Okay. What else do you want to include in this patient's history? What other systems do you think are relevant and you want to focus in doing review of systems? Guys, respiratory symptom. Excellent. So ask me questions related to respiratory system.
So like you've mentioned, shortness of breath, which you do not have.
Okay.
Cough.
Cough, I don't have cough. Yes.
That's all that comes to my mind right now.
Excellent. You are doing really great. I love it. So shortness of breath, cough, at least these things are really relevant. Both are missing in this patient. So that's okay, because this is very important. To know that these symptoms are missing is really as equally important as having them. Okay. That's very important. Other system you want to focus?
GI.
GI is very important because at least 2 differential diagnoses, at least we are considering a possibility of gastroesophageal reflux disease. We are considering a possibility of esophageal rupture. So we have to ask questions relevant to that one. So the most important question would be somebody was trying to ask me whether I had any vigorous vomiting or not. That is very important. If you want to consider spontaneous esophageal rupture as part of your differential diagnosis, you have to ask whether that patient was violently vomiting. I was not vomiting at all. Okay, so that makes your differential diagnosis of esophageal rupture less likely. This is how you approach it. Okay, so you have to ask whether I was vomiting or not. I said I was not vomiting. Actually, I have provided that information. And GI is really relevant. Somebody said pancreatitis. So the characteristic of the patient doesn't go with acute pancreatitis, because acute pancreatitis, most of the time, the location is periumbilical or above the umbilicus, and most importantly, the pain radiates to the back. Severe pain radiates to the back. Most of the time, these patients would have nausea, they will have associated vomiting, and the vomiting tends to be recurrent. Okay, so this information is missing. So at least whoever told of acute pancreatitis, the differential would be almost out. Okay, so GI respiratory symptoms are very important. At least other systems, do you want to really focus as part of the review of systems? Any other systems?
Maybe thyroid related.
Thyroid? Why thyroid?
Because it could
thyroid system የሚባል የለም አይደለ? Let me correct you here. So there is no thyroid system. Where is thyroid grouped?
In the lymphoglandular.
Excellent. So lymphoglandular system. Why do you want to ask questions related to lymphoglandular system? Why are you thinking of thyroid pathology?
Although it's not common for me, that's maybe thyrotoxicosis could have caused the heart condition.
No, thyrotoxicosis, if it has resulted in something, a pathology in your heart, most of the time it's arrhythmia and everything, cardiomyopathy, arrhythmia and all that. But the presentation is not going to be like this, right? So thyrotoxicosis, it's so present in complaints, very typical presenting complaints. So all of a sudden they don't present to you with 20 minutes duration of chest pain. So it's completely out. Don't think about it, okay? So it's out. Anything else?
Musculoskeletal, lower limb pain or swelling preceding this.
Excellent. Excellent. I love it. Lower extreme musculoskeletal system, especially lower extremity swelling. Why is that relevant, my friend?
DVT, most commonly the PEs follows DVT.
Excellent. Excellent. We are considering a possibility of PE, right? So PEs most of the time follow a clot forming somewhere, most importantly in the lower extremity. Sometimes it could be in the pelvic cavity, but most of the time it's in the lower extremity. So you have to ask for travel history, which you have effectively asked it. And you have to ask me if I have leg pain, leg swelling, and all that. That's very important because if a patient has DVT, they have a very high probability of developing PE. And PE in our differential diagnosis. So that history is missing. So musculoskeletal system, particularly lower extremity pain and swelling is relevant. Beautiful. I love it. Any other system you want to ask? Now you got the point. Okay, you guys are thinking now. So I love that.
And Doc, to get back to the pulmonary embolism DVT history, long time bed rest, and if the patient have had any recent trauma, would be also relevant.
No, I answered that question. I said no history of trauma. So there was no history of trauma that is missing. You can ask something else actually as a risk factor if you are thinking about immobility. But the patient told you, I was apparently healthy, I was fine, I was in the office social. So that means indirectly he told you that he was not inactive for a long time. But if that information was missing and if the patient didn't provide that information, you can ask, did you have any recent history of immobilization? Did you have any history of surgery? Or did you have any history of orthopedic surgeries, pelvic surgeries, trauma, something which makes you sedentary? You know what I mean? So those questions you could have asked. But he told you he's apparently okay, he was okay, he was in the office, he's SEO, working fine. Okay. So those things are missing. Beautiful. Okay. Anything else? I love it. Okay. Let's go. My battery is dying, but I'm ready. Don't worry. Okay, sounds good. All right, next slide. So high history of intermittent chest pain. Oh, I have talked about this one, and next one is this one. Okay, past medical history. What past medical history are you interested in? So that I have to go somewhere. I have a funeral service after a couple of minutes. Tolo tolo bitmallisu discussionum tolo alkal. Okay, go ahead, please.
Hypertension.
Hypertension, excellent. Yes, I'm hypertensive for the past 10 years. I haven't been taking my medication. I was very reluctant, the doctor. I was busy. So I started taking my medication last year. So I ignored my health doctor. I regret it. What else?
PM, hypercholesterolemia.
Yes, last time, 3 years ago, they told me my cholesterol was high. I'm just trying to manage it with exercise and manage it with some, food management, dietary management.
Any surgical history address the
Stay in the past medical history. Stay in the past medical history. Past surgical is separate, right? So hypertension, cholesterol.
Because of the risk of recurrence of MI, we might ask if he had the same episode before.
No. Actually, if you are a doctor, if you are paying attention, I told you this history. I told you that I had this intermittent pain which comes and goes. I never had this kind of pain in the past. I already said that, doctor. Please listen to me carefully. Patients may not dare to say that, but sometimes they give you that look, right? So if you ask a question and again.
Diabetes mellitus?
Yes, I do have diabetes, doctor, so I'm just taking metformin for the past 5 years. Anything else?
Do you have follow-up for your hypertension and diabetes?
I said it, doctor, I am like ignoring myself. They told me 10 years ago about my hypertension. I haven't been taking my medication. I am busy and I consider myself healthy. So I just started taking my medication last year. I said it already. So be a good listener, by the way. Be a good listener. That's also a skill. Sometimes you irritate your patients. If you ask them the same question time and again, they give you an answer, you ask them again, they may think you are not listening well. You know what I mean? So be attentive, okay?
You've mentioned you had an intermittent pain that got worse with exercise or with movement. So for how long has that been happening?
The past I said the past 6 months. Doc, please listen to me carefully. I mentioned it earlier, right? So I said for the past 6 months, I had this pain began. So pay attention to the information given to you. I'm glad you asked it, Joe. Okay, what else do you want to ask? Anything else? So this is most probably going in the direction of the heart, right? So when you feel that probably I'm dealing with a cardiac problem, then you want to know whether I have a cardiac history or not. So at least you can say, have you ever had any heart problem in the past? You know, if the patient had history of, say, GF or anything, they can tell you. So some people may tell you, yes, I had, cardiac catheterization done 5 years ago. They may tell you, yes, I have a cardiac stent, or yes, I had a bypass surgery. Yes, so my valve is replaced or something like that. Okay. So just go ahead and ask them, do you have a heart problem, the heart condition in the past? So if there is something they know of, they will tell you. If they don't know anything, they will tell you, no, there is nothing which I know of. You know what I mean? That's a relevant information. Okay, let's proceed. So past surgical history, anything you want to know in past surgical history?
Yes, maybe considering pacemaker as well.
Yeah, but this guy was apparently okay. He told you he never had issues and all that. So to consider pacemaker is a remote possibility, I would say. You can ask like any surgical history, you can ask about anything. So you can simply say, have you ever had any surgeries in the past? Then if I have that information, I'll say yes. In this case, I'm going to say no. So you can simply say, have you ever had any surgeries in the past? Simple. Then when they say yes, then you can ask them what kind of surgery and when did you have that surgery, okay? Then you can elaborate further when they give you a positive history. If they say no surgical history, you don't have to specifically ask about a particular surgical procedure. Is it clear, guys? Are you guys with me? Are you liking the way we are progressing?
Yes, sir.
Yes or no?
Yes.
Yes. Good. All right. So past surgical history, and then what's next? Let's see what's next. Then social history. So Agga was really eager, and some of you were eager to ask questions. So I told you, yes, smoking history, 1 pack of cigarettes. I said 30 years.
Yes.
I'm correct. I'm correcting myself. So for the past 20 years, I'm sorry. It's not the past 30 years. 20 years, I drink alcohol socially, no recreational drugs. I am happy in a way that you guys asked these questions as part of the HPI. You are excellent because, these things could be related to the disease in question or to the pathology in question. So these are risk factors: drinking alcohol, smoking cigarettes, use of recreational drugs, particularly cocaine. They are really relevant in this particular patient. So all these social history components, they can be part of the HPI because they are one way or another related to the HPI. That is the reason why I gave out the answer as part of the HPI, okay? And I love it. And you guys nailed it. So you should ask and you should include it as part of the HPI. It's very important in considering our differential diagnosis in this patient, okay? All right. Let's narrow our differential question. Go ahead, please.
So in the past surgical history, is any kind of fracture like related casts in, like, is it categorized under there? I was just wondering.
I mean, like, you mean any orthopedics intervention in the past, like, POP application, something like that?
Yes, sir. Yes, sir.
Not really. I mean, those are not surgical interventions, right? Unless a patient had history of fracture and open reduction internal fixation has been done, you don't really categorize application of a posterior gutter or POP as a surgical intervention. And most importantly, like I mentioned, you ask a patient whether they had any surgical history or not. If they say yes, end of the story. Well and good, simplified your life. If they say yes, then you have to ask them what kind of surgery, why was the surgery done, when was it done, what was done. This you can go ahead further elaborate. Sometimes it could be directly related to the patient's presenting complaint, or sometimes it could be irrelevant. It's just like, as እንደ ግብአት ታስቀምጫለሽ. I like ግብአት. In the information, you can keep it, but it may not contribute to your differential diagnosis. Let's say a patient comes with vomiting, and patient gives you abdominal surgery history, that's relevant, right? Because it could be adhesion with a small bowel obstruction. So in that case, the surgical history, the abdominal surgery is relevant for somebody who came with failure to pass feces flatus and vomiting of ingested matter. But for this case, for example, abdominal surgery has nothing to do with the current complaint. I will just ask, I will just understand what has been done for them. That's it. So then if they had history of surgery, you can go ahead and ask them about anesthesia history, whether any history of allergy to any anesthetics, and also so all sorts of stuff. That's important, especially because if you are thinking of doing certain procedure under anesthesia, that's a very important information, and you have to take that opportunity to dig into that one. All right? Do you get my point? Let's narrow our differential diagnosis. So which ones do you want to keep? Which ones do you want to kick out? So MISS angina, keep or remove?
Keep.
Esophageal rupture, keep or remove?
Remove.
Remove.
Let me copy and then let me take it there so that if you guys use it for future reference, you will have it available. So narrowing differential diagnosis, I will paste it here. Then we will remove. So esophageal rupture, remove, because we talked about it. Patient didn't have any, like, spontaneous vomiting, recurrent vomiting, very aggressive vomiting alone, so less likely to have esophageal rupture. What about PE?
Remove risk factors.
Remove. Some may say
down.
I will still keep it. Some people still may get obsessed because P is important, you know what I mean? So we may still keep it. I will tell you the reason. So, I mean, you may not be, based on this history, you may not be 100%. Yeah, actually, now, if you ask me, the risk is low. That's why I'm taking it down. But still, you may have, like, clot within the pelvic cavity, especially this guy is a smoker and all that. We never know, this guy may have malignancy. We never know, this guy may have high tendency to develop clots and everything. You never know. So P is still a possibility. So let me keep it down. It's very less likely. That's why I'm taking it down. Angina, it goes with this thing. If at all this is angina, is it going to be stable angina or unstable angina? Huh?
Most likely unstable.
Unstable angina. And unstable angina is part of the ACS, right? So acute coronary syndrome, you have unstable angina, you have NSTEMI, you have MI, right? So those are the three things. So it's inclusive. We can say simply ACS, so acute coronary syndrome. So that entails, like, NSTEMI, STEMI, or, like, unstable angina. So we can keep ACS most likely. Pericarditis, myocarditis.
Remove.
Remove. They are less likely. The characteristic of the pain is not going with pericarditis particularly. It's not position dependent, because, like, pericarditis, as you know, the pain gets worse in supine position. It gets better when the patient is sitting forward, leaning forward. That characteristic is missing. No predisposing factor as such. I mean, TB, we cannot think of TB. This is an acute illness just presented with 20 minutes history. Myocarditis, pericarditis, less likely in this patient, so it's going to be kicked out. Aortic dissection.
Remove.
Why remove? Do you agree, guys? Do you want to remove it? Somebody who wants to say no,
No,
don't
keep
keep
it.
it. Keep it. We'll
Keep
keep it because yes,
Yeah.
thank you so much. We still
The
keep it.
patient has the risk factors, right? Hypertensive, no. Smoker, no.
Excellent. Excellent. So smoker, hypertensive patient, male patient, the characteristic of the vein behind the sternum, we have to keep it. So aortic dissection actually sudden tearing type of pain. It tends to radiate to the back, to the spine. So that characteristic you didn't ask me. Actually, you asked about radiation. I told you to the shoulder, but be specific. You know, sometimes ask patients specific questions. Does it come to your back? Ask them that question. That's very important because patient may not tell you that information. But they may say yes when you answer, when you ask it. All right. So aortic dissection, it still stays, and most probably it should stay up. Okay. What about gastroesophageal reflux disease?
Let's kick off.
Yeah, kick off. If you want to kick it off, you can kick it off. You can keep it. You can also keep it. I don't mind. Most probably you can kick it off. Let me kick it off. Okay, because like I said, gastroesophageal reflux diseases tend to be a chronic problem, and most of the time the pain gets worse at night. It's not like suddenly presenting like this, you know. It's associated. It's most of the time tends to be postprandial, especially at night and all that. That history is missing, and it just happened today. Less likely to be this is all of gastroesophageal reflux disease. What about pneumothorax? Pneumothorax. የት ነው የምትገቡት? መሀል ላይ ልም ትላላችሁ እ ሪሙቭ እስቲ እንትን አርጉ፣ እስቲ ቮት አርጉ። ሪሙቭ የስ ኖ በሉ። Yes is for remove it, no is keep it. Let me see how the audience is responding. Yes versus no. No is keep it, okay? No, but keep it down, okay. Yes is remove it. See, text argo. Yeah, let's keep it, okay? Let's keep it for now. Let's keep it for now. Let's keep it. It doesn't harm us. Let's keep it. This is still possible. Costochondritis. You want to keep it or you want to keep it out? Remove it because the characteristic of the pain doesn't really go with costochondritis, right? So you may want to keep it until you do physical exam, but like, you know, just kick it out. It's less likely, or like, you know, I wouldn't really be bothered about costochondritis because costochondritis wouldn't be radiating to the jaw or to the left arm or things like that. This is not characteristic of costochondritis. I'll kick it out. Panic attack?
Keep it, but like towards the bottom.
Yes, keep it, but in the bottom. It's a diagnosis by exclusion, so we'll keep it down. So now you see how we effectively narrowed down our differential diagnosis just by taking history. That's why, like, you know, people tell you medicine is an art, and it combines history taking, doing physical exam, okay? By listening to your patient, by taking a very good history, you may be able to make a diagnosis in about 70%, 75%, 80%, sometimes even more than that, if you have typical history and all that. So this is how you keep it down. So pleurisy, is it? Yes. Yeah, why not remove pleurisy pain characters? Yeah, so pleurisy also less likely. I'm kicking it up. So I did it on purpose. I didn't even ask you whether to keep it or remove it. So because I want to see your thought process, and I love it. Mary, you came up. So we have to take it out. It's not typical. Okay. All right. So we have 1, 2, 3, 4, 5 differential diagnoses. Yes, go ahead, please.
I would like to ask, would you have added any more differentials in the differential other than this?
I love it. Tell me.
No. Like, I'm asking you, is there any differentials?
Don't ask me. You are the doctor. I'm the patient. Add. If you want to add, and we will see if you can add that differential in the head.
No, there is not.
There is not. Thank you so much. I am your patient today. If I keep quiet and if I am jumping to a different slide, most probably that means FSH doesn't have nothing to add, Malan. No. So just, I mean, by exclusion. But if something pops up, then I will challenge you, okay? Later on. If you have missed something, I will, highlight on that one as well. Sounds good? Guys, don't leave this session before we finish, okay? Things will get more interesting as we go along. All right, so physical examination. Which systems do you want to examine in this patient?
The pericardium.
The precordium. The precordium ስትይግን በጣም ጠብ ነው የሚገጥምሽ። እኔ ሁሌ ጣላ ነበር precordium ምናምን ሲሉ ዘለው. That is not the principle we teach you, right? So what is the principle you follow in physical exam? Your approach should be stepwise. Vital first, Dr. Meron, you missed.
General appearance. I should say general appearance.
I love you, Kirubel. I love you. Yes. So you start from the general appearance, right? That's very important. So, I mean, this guy is in pain, right? So there is a lot of information you can get by looking into the general appearance of this patient. Am I correct? Excellent. So I will tell you the pain is really in pain, acutely sick looking. He's sweating, okay? Acutely sick looking in pain. And he has some sweats in his face. And next. So that's one of the common mistakes done by medical students when they are asked about physical examination findings is they jump into the positive examination findings. Always start from the general appearance. The general appearance tells you a lot. If the patient was chilling, if the patient is reading a newsletter, patient is like, giggling with friends and family, I am fine because the patient is not dying at least, you know what I mean? Patient is gasping for air, patient is in excruciating pain, patient is sweating, patient is breathing hard. All this information you can gather by looking at the patient's general appearance. That means a lot. I'm dealing with something serious, you know what I mean? So general appearance is important, and don't forget, don't ever, never forget mentioning general appearance when you are asked about a chilling person, patient who is really critical. In every patient, general appearance is important. I want to emphasize on that one. The next is, after general appearance?
Vital signs.
Vital signs. Obviously, this is a patient who is hypertensive. He told you now the blood pressure is 180 over 105. Is it concerning? Is it concerning? Say yes, of course, this is not a normal blood pressure, 180 over 105. In fact, this patient is fulfilling a diagnosis criteria for what? Hypertensive urgency, right? So at least if he fulfills diagnosis of hypertensive urgency with this blood pressure. Okay, heart rate is 82 per minute, respiratory rate is 22, temperature is 37, saturation is 97%, okay? Which other system do you want to examine? አይታችሁታል ኦልሬዲ ግን ያው እንዳው ትንሽ ሜንታል ኤክሰርሳይዝ እንድታደርጉ ብዬ ነው። ከሪስፓራተሪ ሲስተም በፊት ማን ይቀድማል? የትኛው ነበር የሚቀድመው? ሪስፓራተሪ ነው ካርዲዮቫስኩላር ነው የሚቀድመው? Cardiovascular, right? So you talk about cardiovascular system first. So S1 and S2, S2 are well helped, regular, no murmur or gallop, no extremity swelling. Okay. What other system do you want to examine?
Sir, I have a question.
Yes, go ahead, please.
Shouldn't the respiratory come first as we want? Are we not considering it because he's talking and we assume that his airway is intact?
No, we do consider it. Then you wanna step ረስቼዋለሁ። ምንድነው general appearance comes first, then vital signs, ከዛ HNT, then lymphoglandular, ከዛ በኋላ ማን ነው የሚመጣው? Which system follows after lymphoglandular system?
Respiratory system.
Respiratory.
Excellent. I think it's respiratory system. Yes, I'm sorry. So who said it's cardiovascular? I want to give the blame to somebody. I want to blame my brain.
Me.
Okay, you are the one who is supposed to be blamed. I'm the patient for today. So respiratory system. Okay, go ahead. Respiratory system is actually important, and I ignored it because there was no finding in the respiratory system. But in this particular patient, it's very important. I should have something about the respiratory system. I will tell you orally. There is no, I mean, the patient is not like, having signs of respiratory distress, no subcostal retraction, no intercostal retraction, no use of respiratory accessory muscles, clear air entry bilaterally, both in the anterior and posterior basal lung fields, all over the lung fields. No good air entry, comparable bilateral, okay, and resonant all over the chest. Tactile fremitus is normal, and everything. There is no finding. In general, in summary, there is no respiratory finding. And cardiovascular system, I told you. Any other system you want to examine, which is not mentioned here?
The lower extremities.
Excellent. Musculoskeletal system. Excellent. Musculoskeletal system. As part of the musculoskeletal system, you emphasize lower extremity examination. There is no finding in the legs. There is no leg swelling or anything. Okay. Sounds good. Let's narrow differential diagnosis again. Okay. Which ones do you want to keep? Which ones do you want to exclude now after doing physical exam? Let me bring whatever we have narrowed down here. Oh, that's not it. Tell me, guys, which ones do you want to keep? Which ones do you want to remove? After the physical exam.
Remove pneumothorax.
Remove pneumothorax. Okay. Excellent. I love it. We'll kick out pneumothorax. What else?
Aortic dissection.
Aortic dissection? How can you exclude aortic dissection at this point?
Because the patient's hypertensive. I think he's supposed to be hypotensive.
No, not necessarily. It's just a dissection. He didn't rupture. In fact, the fact that he's hypertensive makes him at risk for aortic dissection, right? Uncontrolled, significantly elevated blood pressure with chest pain or external chest pain. This Can you mute the effects? I target mute target bachavat. Kitchen zello. Okay, aortic dissection. In fact, he is at a very high risk, by the way, because blood pressure is significantly elevated and came with external chest pain. You want to still keep it. Anything you want to exclude now?
The PE.
Pulmonary embolism less likely. You can investigate further, but things are in the direction of PE is becoming less and less likely. Pneumothorax, what about pneumothorax? We say it has to be excluded because as such, we have comparably good air entry and there is no reduced air entry or hyperresonance and all that. So pneumothorax is less likely. So aortic dissection is staying, SAS is staying, panic attack is staying. Do I agree?
Yes, sir.
Are we really interested this much in panic attack? Because
yes, of course. Why not?
I know it's like diagnosis of exclusion, but the presentation of this patient and then our history.
Exactly. This guy is not as such at risk for panic attack. Like I told you, if you remember what I said earlier in the presentation, if this patient was a female patient, young patient and everything with a similar history in the past, panic attack could be considered, but he can still have a panic attack. You know what I mean? He may be anxious, he's worried, he's in pain, you know what I mean? But the only thing is, panic attack wouldn't explain the fact that the pain is radiating to the left shoulder, right? So that's a good argument.
Yes.
I love it.
Yeah.
I'm so happy that you raised it, and panic attack should be kicked out at this point, especially because of the characteristic of the pain. Even though it mimics a heart attack, now we can safely take it out because, you know, it looks like the pain persisted and it's radiating to the jaw, to the arm, and to the shoulder. So we can effectively remove it. Thank you so much, sir. I appreciate that. Now you guys are engaging, right? So I love this. So now we have two competing differential diagnoses, ASAs and aortic dissection. So what shall we do next? You know, how can we differentiate between the two?
Cardiac biomarker.
Huh?
Sending investigations.
Investigations. Thank you. So what investigations do you want to do?
Cardiac biomarkers. ECG.
So P is out. ያወጣሁት መስሎኝ ነበር. Panic attack is out. Aortic dissection እና ኤስኤስ ነው የቀረን። ኦኬ እዚህ ጋር እንዴት ገባ ታዲያ? ናሮዊንግ ዲፈረንሻል ዳያግኖሲስ ብዬ ናሮዊንግ ዲፈረንሻል I made a mistake. I made a mistake, I guess. Okay, so I made a mistake. So that one is okay. የሆነ ሜስ ፈጥሬያለሁ ብቻ ይቀርባልኝ። I made a mistake. Anyway, ስለምታዩት whoever is following the slides would understand. So now
አሁንኛው ስላይድ ላይ የጠፋ ፓኒክ አታክ
እዚህኛው ላይ ይጠፋል፣ እዛኛው ላይ ኪፕ እናደርጋለን። That's what happened. So I will take it out from here. All right. So we are here. So the next step is to send out investigations. So tell me the investigations you want to add. Okay. ፈጠን በሉ. Like I told you, I have a funeral service እና እንድንጨርስ
EKG.
EKG, yes, 12 lead EKG. Yes,
Basic CBC and the like.
Basic CBC, BMP, they are unremarkable except elevated blood glucose because he's diabetic. Okay.
Cardiac biomarkers.
Yeah, high sensitivity troponin or troponin, whichever is available, it's elevated. Okay.
Echo.
Echo can be considered. Not right now. You may delay it. You may want to do it right now. So echo can be considered. Okay. Before echo again, lela alla adalla.
Just X-ray.
EKG ብላችሁኛል? Did you say EKG?
Yeah.
Yeah, and chest X-ray is very important, right? And in fact, chest X-ray would help you to exclude most of the differential diagnoses, including pneumonia, whatever, you know, cavitary lesion, pneumothorax, whatever, pneumomediastinum, all these kind of things, the chest X-ray would help you to exclude. So chest X-ray is unremarkable. That supports how we narrowed already. So that is further strengthening our differential diagnoses. So there is no lung-related pathology, no pneumothorax, no pneumomediastinum, and all that. All right. And anything else you want to do? Lipid panel you can do. You know, you may do it immediately, you may do it later. And that helps you. Actually, the patient has told you he has elevated cholesterol, but right now we confirm that he has total cholesterol is elevated. LDL is elevated and HDL is low. Okay. So these are very important. Any additional tests you want to do? So I'm going to show you the EKG. What do you see in the EKG?
Maybe before that, doctor. Is there any value for bedside ultrasound, especially for the aortic dissection?
No, not necessary. I mean, even the chest X-ray would tell you something. If there is aortic dissection, most of the times there will be mediastinal widening. We didn't see any mediastinal widening, so that further decreases the possibility of aortic dissection. Okay. And the pain, the characteristic of the pain is also not as such typical. Like I said, substernal chest pain with radiation to the back is very characteristic of aortic dissection. And most of the time it doesn't tend to radiate to the jaw or to upper extremities or to the shoulder. Okay. That makes a possibility of dissection late, and the chest X-ray is being normal and mediastinum is not widened, also further decreases the possibility of having seeing an aortic dissection in this patient. Okay. Anything else?
Sir, somebody in the chat group also said random blood sugar to check for the DM status.
Yeah, I mean, I told you here. So I said unremarkable except elevated blood glucose. In fact, I said because he is diabetic. You guys should listen. Okay. Be a good listener, by the way. Be an observant and listen attentively. All right, so here is a EKG. What do you see here?
Can we make it full screen?
Full screen larga? I'll do that.
On.
Do you see any ischemic change?
Yeah, those peak T waves.
Huh?
If I'm not mistaken, I believe there are peak T waves on lead V2.
Is this one? No, that's normal. I would say this is normal. Do you see any ischemic changes like, ST depression or ST elevation or T-wave inversions in any of the leads? Not really, Adam. Not really.
Significant
There is no. Yeah, there is no as such significant. I mean, like if you see here, it looks like elevated, but it is not. From the isoelectric point, J.2, as such, elevated RLM, it has to be more than 2 millimeter elevation, right, to qualify as ST segment elevation in V2, V3, and others. So, as such, there is no T-wave inversion LM in any of the leads, ST depression LM, ST elevation LM. So, EKG is as such okay. So, if we are still thinking of acute coronary syndrome, which one are we dealing with? Because I told you it could be unstable angina, it could be STEMI, and I told you it could be STEMI. So which one are we dealing with if it is SAS?
Stable angina.
Huh?
STV elevation in
Unstable angina, Nelko?
Stable.
Do you guys agree with unstable angina? The stable angina.
No.
No, stable angina. This is not a stable angina, my friends, because I told you he had a stable angina in the past, which used to come with exercise. It goes away by taking rest, and that has been going on, coming and going for the past 6 months. That is a stable angina. It was not worsening. It's not changing its character. Right now, it changed its character. It stayed the same. It gets worse. That is defined as unstable angina. So, are we dealing something above unstable angina is a question. So are you guys dealing with unstable angina or an STEMI or a STEMI? It's not a STEMI because there is no ST segment elevation in this case. So STEMI is out. So which one are we dealing with? An STEMI or unstable angina? Based on the information provided, I have given you an information which would help you to differentiate between the two.
Because of biomarker elevation, I think non-STEMI.
Non-ST elevation MI, excellent. Thank you so much. There is cardiac injury, there is enzyme leak. We are dealing with something above unstable angina. It's not simple unstable angina. It's more than that. The troponin is elevated. So most probably we are dealing with an STEMI, okay? Okay, so now other investigations, echo can be done, cardiac stress test can be, entertained, but not right now because he has, troponin leak. And this patient may have an active MI, and you don't do stress test in a patient who is having MI because you will worsen it, okay? You have to be careful. So if it was just simple unstable angina, you can think of cardiac stress test. If it was non-specific chest pain, you can think of stress test, doing a stress test, but not for this patient. You may kill the patient on the treadmill. Okay, you have to be careful. And cardiac CT, if the patient presented a couple of months ago, you can think of cardiac CT, do calcium scoring and all that, and you will see the coronary calcium score and everything. You can do that, and you will risk stratify the patient. Okay, cardiac MRI, not right now, but like if the patient was, coming during the angina symptom, even now you can do MRI. MRI can tell you whether there is ischemia or not, because you can tell whether the part of a myocardium is, being perfused or not. Okay. Cardiac MRI can be considered, but not right now. Maybe this patient is having an acute problem. Sending him for an MRI could be fatal, especially if the disease progresses, and sometimes cardiac MRI takes time to be completed, and you may lose the patient on the table of the MRI. So you have to be careful. But theoretically, cardiac stress test, cardiac CT, cardiac MRI, cardiac catheterization. So we are not there yet. So cardiac catheterization, we'll deal about it later on, okay? Just leave it there. So narrowing differential, now do you want to keep SAS and aortic dissection, or you want to keep only one of them? Probably, huh?
Thank you.
ድምፅሽ አይሰማም. Whoever is speaking, your voice is distant.
I'll keep the ACS. Sorry, sir.
Yes, let's keep ACS and probably kick out, aortic dissection because there was no mediastinal widening. The chest pain was not as such characteristic. So we keep ACS for now, and then probably, it's less likely that we are doing with aortic dissection. So anything to do with the patient? In the meantime, now, I mean, our discussion took almost 2 hours, but it shouldn't take you this long to intervene in this kind of patients. So what do you want to do for these patients? Patient with sudden onset substernal chest pain, you are suspecting a possibility of SS. What do you have to do in the meantime? And the pain is severe. It is 9 out of 10. I told you earlier, kill the pain, right? So give him something for the pain. So you can give nitroglycerin. How does nitroglycerin work?
Vasodilation?
Vasodilatation, excellent. Vasodilatation, so the perfusion to part of the ischemic part of the heart gets improved, then the angina pain would get better. Because, I mean, you have the angina because the oxygen delivery to heart muscle is low. So you can give nitroglycerin. Let me tell you, this patient was taking nitroglycerin. He was given 3 times. It was improving at first, but later on, the pain gets worse despite repeated administration of nitroglycerin. What do you want to do next? What other medication?
Antihypertensives, maybe, to help.
The antihypertensives you can give him, but that doesn't help you with the pain, right? So what else do you want to give him to help him with the pain? Because these people are panicking. They feel as if they are dying. They are anxious. So you have to alleviate their anxiety. Otherwise, you are making the problem worse and worse. It's a vicious cycle. They are more stressed. They are panicking means they are straining their heart because they are anxious. The heart is pumping fast. The oxygen requirement is increasing. You are aggravating the heart muscle damage. So you have to alleviate their pain. You have to also alleviate their anxiety. So what medication is given for that reason? Come on, guys. The doctors, Aganesh, Meron, and Fitsum, Dr. Fitsum. Dr. Fitsum, are you still here? Dr. Fitsum, are you here? Zex, Dr. Fitsum is here? Zex himself is absent. Zex, are you here?
He is present. Fitsum is not here, doctor.
Oh, Fitsum is not. Okay. All right. So that's fine. Whoever wants to give an answer, Mary or
anxiolytics.
Opioids such as morphine.
Or anybody who wants to answer.
There are answers on the chat box. So nitroprusside and morphine are answered on the chat box.
Morphine, excellent. I mean, tell me that I'm not looking into the chat box. That was why I was asking Zex. So if you see any answer written there, let me know, okay? So because I'm not following that one, I couldn't display that. So yes, morphine has to be given. Morphine would help you alleviate the pain, plus it alleviates the anxiety to a certain extent. What else do you want to give? The answer is here. I mean, whatever you need to do. What do you want to give them?
Oxygen supplementation.
Oxygen, why? His saturation is 97%. Why do you need to give him oxygen? You don't need to give him oxygen unless there is a desaturation. Unless the saturation is less than 95%, don't provide them with oxygen. The oxygen is toxic when you give it to somebody who doesn't need it, okay? Oxygen is not required. Answer whatever is written here. You have to give them aspirin. Aspirin is important. Why do you give aspirin? High dose aspirin. Why do you give them high dose aspirin?
Prevent clot formation.
Yeah, so I mean, the pathophysiology of acute MI is just because of plaque rupture, no? So there is a clot formation. So in order to discourage further clot formation and complete occlusion of the coronaries, you have to give them aspirin, antiplatelets. Okay, that's very important. And then beta blockers. Why do you give beta blocker?
To decrease the straining of the heart, to give it time to fill.
Yes, the beta blocker, what it does is it reduces the heart rate. When you reduce the heart rate, that means the heart is beating slow, and now oxygen requirement, the oxygen demand by the myocardium becomes low. So you'd reduce the further damage ማለት ነው cardioprotective ነው prognostic implication አለው beta blockers say improve survival after MI so beta blocker should be instituted but you have to be careful whether you have got inferior well MI or not so it could be devastating if you have inferior well MI so you have to be careful before you go start beta blocker if a patient comes with acute heart failure also you have to be careful if the patient has already acute heart failure don't give beta blocker it may worsen it okay so you have to be careful before you start beta blocker but it could be started. And atorvastatin, you can give a statin as well. Okay, you can start them on high intensity statins. That's very important. So let me tell you the progress in the ED. While waiting for cardiology consult, yes, quiet, please.
Should we also add thrombolytics for this patient, especially if they come within like the 3.5 hours, within 3.5?
No, not really. Not really. We'll talk about that. So we'll talk about like, giving thrombolytics or not. There is a principle behind it. We'll talk about it later. Okay. You don't give it in every center. Number one, it's not available everywhere. And number two, you have to make sure that you are dealing with something serious before you give thrombolytics. You don't give thrombolytics for an STEMI, for example, right? So you give thrombolytics if it is a STEMI. At this point, it is not a STEMI, at least. You got my point? It's not STEMI. So you don't need to give thrombolytics at this point. So the progress while waiting in the cardiology consult, patient's chest pain worsened about an hour later to my presentation to the AD, became more intense as if elephant was sitting on my chest. Worsened shortness of breath. Now the shortness of breath became most important. Saturation dropped to 89%. I am more diaphoretic, very anxious. What shall we do next?
Repeat the EKG.
Repeat the EKG, excellent. So repeat nitro dose, give them nitro, give them morphine, repeat 12 lead EKG, okay? Things are worsening. Now I am becoming more anxious. Not only the patient, the physician should also become anxious, okay? Because things are worsening. You never know what's happening. And bingo, here is a surprise. What do you have here?
ST elevation.
ST elevation MI, you can see ST segment elevated, elevated. So anterolateral MI is hooking. Most probably the left anterior descending artery is completely blocked. It's potentially fatal because most of the left ventricle is going to be affected. So that's why I said not only the patient, but the physician should also start panicking. You have to plan for something. So this is what is meant by ST elevation. This is isoelectric point, and then the J point is around here, more than 2 millimeter elevation, ST elevation. All right. You see, this is very typical. ST segment is significantly elevated in this patient. So this is hypothetical patient. You can you see the ST segment is so elevated. This is the isoelectric point. It's significantly elevated in the anterolateral leads, okay? So ST segment elevation MI is going on. So what shall we do next? So who can summarize this case in one line? Who wants to summarize it? Are you guys bored? Yes or no? Are you guys bored?
That was interesting, sir.
Very interesting. But I want to hear from everybody. Is it interesting or you guys are bored, tired?
It was interesting.
Excellent. So summarize it if it was exercise. I mean, interesting ከነበረ summarize አርጉና አስደስቱኝ. Just summarize in one line. Because I am the interventional cardiologist and you are the you called me, I'm busy. So my nurse told you, oh, Dr. FSH is doing, coronary intervention. He's in the middle of a procedure. Do you have anything to say for him? Then you say yes. And I asked the nurse to give the phone to me. They are holding it to me. And I'm telling you, sir, I am in the process of fixing somebody's heart. I don't have time. Just tell me what's up. What do you have? Summarize. Tell me now.
This is a 62-year-old male patient experiencing MI.
Experience. Nice, nice. I like it. But how did you end up diagnosing MI? You are an intern, and I'm telling you, I'm an arrogant interventional cardiologist. And I would laugh at you, you know what I mean? What? MI? What do you diagnose MI, my dear? You know what I mean? Give me a little bit more. Summarize it, but give me a little bit more information.
So this is a 62-year-old male patient presented with substernal severe chest pain that radiate to the left upper. Then the investigations EKG shows the elevation S2 to S3, and the cardiac biomarkers are highly elevated.
Excellent. So this is much better. So you can say, I have a patient here in the emergency department, 62 years old male patient, presented with a chest pain, 20 minutes duration. And now troponin is elevated. Initial EKG, there was no sign of ischemia, but while he's waiting for you, pain gets worse. We did EKG again. ST elevations are everywhere. He has elevated troponin. He's very anxious. He's desaturating. Initially, it was 97%. Now it's 89%. What shall we do? We are giving him morphine. We are giving him nitro. It's not helping. You see, it's comprehensive, very summarized. So I know what you guys are dealing with. I know what I am expected of doing. So what shall we do next? Now we have diagnosed the STEMI. So what is the next step?
Now consider the thrombolytics. I believe if the 3.5-hour gap window is not closed.
Excellent. You are in the right track. Again, before you jump on thrombolytics, what is the best treatment modality for STEMI? First line treatment.
On the group chat line, PCI below ጽፈዋል.
Excellent. They are right. It's PCI. But if you don't have PCI, there is no PCI. Let's say there is no PCI in black line. I couldn't do stenting. Then maybe, I have to transfer you to a cardiac or somewhere, wherever there is cardiac catheterization actively done during emergency hours. So if I have to transfer the patient to somewhere else, then, and if I cannot make the transfer within 120 minutes or 2 hours, then the idea of giving thrombolytics comes. ገባሽ እህቴ? Why I was ignoring your answer, the thrombolytics, I was not really excited about that answer because thrombolytics is second line. If you cannot do PCI right away, or if you can't do it, you have to transfer to a patient where there is PCI. And if it is if you are sure the patient wouldn't be there within 2 hours, then you have to go ahead and give him thrombolytics if it is available. And then once you do, and the other thing is this patient is a candidate, right? Because he came immediately after the onset of symptoms. He is in that window for thrombolytics. The patient has to present within the first 12 hours. This patient came 30 minutes after the onset of his symptoms. So he's a good candidate because thrombolytics is effective if it is given within the first 3 to 6 hours from the onset of symptoms. Okay, so that is your second line. Since the patient is in black line, okay, there is no PCI, and you are not sure whether you are going to be able to transfer into another center with 2 hours, then you can talk about thrombolytics. Unfortunately, I don't think thrombolytics are given in black line. Then this is going to be just a theoretical discussion. So then, if you cannot do anything, other treatment modalities has to be given. What else can you give him in the meantime? What other blood thinners can be given to this patient other than thrombolytics? Right now, we have as a further differential diagnosis narrowing, we have got STEMI, አይደለ? Initially, STEMI ነበር, progress አረገ. STEMI, which progressed to STEMI, right? So on, we are sure we are dealing with STEMI. So what else can you give this patient? Is it too much to you guys?
Sir, somebody had heparin.
Yes, heparin. You can start heparin infusion. That can help, whether it is anestemy. If it was also anestemy, you treat them with heparin infusion because you don't have to do PCI right away. That's why I said we'll talk about PCI thrombolytics for anestemy later on. Anestemy, you can still do PCIs, but the PCI is going to be sometime later. So if you do it within the first 72 hours, you are still fine. You don't have to do it right away. STEMI, from door to balloon, they say 90 minutes. So if Black Lion was equipped with PCI, then the patient should have his PCI done within the first 90 minutes after his presentation. Door to balloon should take maximum 90 minutes. That's how hospitals which are capable of doing PCI are graded in the US. Okay, that time will be taken. The system knows what time the patient has come, and the system knows what time the PCI has been done. Those they will be graded. If they cannot do PCI within the first 90 minutes, that's a big blow to the hospital, especially if they are capable of offering PCI. Okay, door to balloon time 90 minutes. So give aspirin, give clopidogrel, give fibrinolytics, thrombolytics if you cannot offer PCI right away. Give heparin, morphine has to be given, beta blockers, AC inhibitors, they do have cardiac remodeling effect. The statins, high intensity statins, atorvastatin, like 80 milligram and all that should be given, or rosuvastatin, I think 20 milligram and all that. Okay, PCI or CABG, depending on. So the first thing you should do is cardiac catheterization. So you do angiography. Based on the angiography, you decide what to do. So if the patient is amenable for PCI, you go ahead and do PCI. If the patient is a candidate to undergo CABG, for example, triple basal disease, complex pathology, and all that, CABG has to be done, or coronary artery bypass graft on emergency basis, if the service is available. And cardiac rehabilitation has to be considered after the patient is discharged. So cardiac rehabilitation entails physical exercise, dietary modification, social risk factor modification, like, cessation of smoking, cessation of alcohol, regular exercise and all that. Okay. And good blood pressure control and all that. Are you guys good?
Yes, sir.
Was it helpful?
Yes.
Are you happy?
Yes.
You should be happy. Okay, so I'm going to stop sharing this slide and I'm going to give you a couple of questions. Okay, if we have time, tolo ግን መመለስ አለባችሁ. I have a funeral service. I have to go, my friends. Okay, let me share this slide. Where is that? Where is that thing? Come on. Where are you? Where are you? All right. If you have a question, you can ask me questions in the meantime. ጊዜ ስለሌለን ጠይቁ እስከዛ ጥያቄ የላችሁም? ስትሽኮረመሙ ዜክስ አለ የለም? ዜክስ
አለው ዶክ።
የሆነ ጓደኛ ጠርቶ ነው የመጣው አሁን።
እኔ አተፈልጊ ነበር።
እየቀለድኩ ነው። ዜክስ ብል ጥለኸኝ በርሃል አንተ።
ይቅርታ፣ ወጣ ብዬ ነበር፣ ተመልሼ መጥቻለሁ። ግን
እሺ፣ you missed a lot of stuff።
አረ ነበርኩ፣ ማኔጅመንት ነበርኩ።
እሺ፣ ቆይ ልናይ ነው ማኔጅመንት ላይ እንደነበርክ እንዳልነበርክ።
Sir, somebody in the chat. So sorry, interrupting.
Go ahead, please.
Somebody asked in the group chat if nitroglycerin has any diagnostic value.
Yes, I mean, indirectly it may help you. I mean, like, if the patient gets relieved with nitroglycerin, somehow, that tells you that you might be dealing with some sort of angina, right? So in that sense, it may help you.
Thank you.
Sounds good. So here is a question. I'm going to read it because, you guys wouldn't volunteer anyway. So I will volunteer to read it for you because I'm rushing right now. A 58-year-old man is evaluated in the emergency department 30 minutes after onset of severe and persistent chest pain at rest associated with diaphoresis and nausea. His medical diagnoses include hypertension, hyperlipidemia, treated with amlodipine and atorvastatin. An EKG is shown. Do you see the EKG?
Yes.
All right. So what's going on in the EKG? Can you say something about the EKG?
Elevations in the inferior lead.
Yeah, there are ST segment elevations in the inferior lead. Where else do you have ST segment elevations? Yes, there is like an ST segment depression and 2-wave inversion in V2, right? And in V3 as well, there is some segment of ST depression allezi. እንዳልከው ኢንፌሪየር ሊዶቹ ላይ ሊድ 2 ላይ ሊድ 3 ላይ እና ኤቪኤፍ ላይ ክሊር ኤስቲ segment elevation አለ. There is also some degree of ST segment elevation here in V5 and V6. Okay, let me read it. On physical exam, blood pressure 159, high blood pressure 50 per minute, respiration rate is 18, oxygen saturation is 94, with the patient breathing ambient air, BMI is 25. All other physical exam findings are unremarkable. The nearest percutaneous coronary PCI center is located 140 minutes away. Which of the following is most appropriate management? CT angio, thrombolysis, and admission to telemetry bed, thrombolysis and transfer to PCI center, transfer to PCI center for primary PCI.
B.
Huh?
B, A, B.
B, ሌላ የሚመልስ አለ? B ብላለች እህታችን።
C ብሏል ግሩፕ ላይ።
ሲ ብዙ ሰው ምንድን ነው የሚለው? ቢ ነው ሲ ነው የሚለው? ሲ ነው የሚለው? ልንካው ይፈነዳል ኮምፒውተሩ ከተሳሳተ።
ግን 140 ሚኒትስ ሆኖታል። 90 ሚኒትስ ነው ፒሲአይ ቅድም ያለው
እኮ ፕሮሰስ አድርገሽ ንገሪኝ።
ቢ ብለናል። ቢ ያለኝ
ፕሮሰስ that information and tell me the answer. C or B? Which one is dominating the chat box line? B. My computer will explode. የመጨረሻ አንድ በሉና የመጨረሻው ሜሴጅ ሲ የመጨረሻው ሲ ነው። እሺ ሲ ልበል ኮምፒውተሬን ኤክስፕሎድ ከሚያደርግ። Okay, come on. Help us. Yes, C is the answer. Why is C the answer? So B says thrombolysis and admission to a telemetry. What are you going to do by admitting a patient? Like, you know, what it says is the nearest PCI center is 140 minutes away. I told you earlier, if you are not able to transfer the patient within the first 120 minutes, you have to give thrombolysis, but it doesn't stop there. Thrombolysis is temporary. The vessel can block again. So that means it has thrombolytic treatment has to be followed by a PCI. For that reason, you have to transfer the patient to the PCI center. You don't have to admit to the same hospital where there is no access to PCI. That's why we talked about transferring the patient out of Black Line to private center where there is PCI access. And the reason why you are giving thrombolysis to this patient is because you know that you cannot transfer the patient within 2 hours. It takes 140 minutes. That's why. If it says it takes only 60 minutes, you still transfer the patient to that center without doing any PCI or without giving thrombolysis. And they will manage him there with PCI. ተዘጋጅተው ቀጥታ ወደ ካትላብ ይወሰዳል። ኢዲ አይወሰድም፣ ምን አይወሰድም፣ ቀጥታ to the cath lab, and the cath lab team would be ready. The moment patient is in the room, they prepare, they do the procedure. You got the point? That is the reason why B is not the answer. So patients with ST elevation myocardial infarction, thrombolytic therapy is recommended if symptom onset is within 12 hours and primary percutaneous coronary intervention is not available within 120 minutes of first medical contact. Sounds good?
Yes, sir.
There was another question. Again, which one is it? I am not sure. I have a funeral and I am kind of rushed right now. I wish I would get the answer, the question. I would, oh, come on, go away, 59, question 59. This is not, okay. Oh, this is also interesting, actually. Okay, so a 65-year-old man evaluated the 2-day history of several episodes of chest discomfort, dizziness occurring both at rest with exertion. Today, he presented with 3 hours of persistent severe central chest pain. On physical exam, blood pressure is 155. No, this is not what I was looking for. I think it was 29. No, 29 አይደለም 51 አረኩኝ what okay a 73-year-old man is evaluated in the emergency department 2-hour history of crushing chest pain diaphoresis EKG is this one so what do you see here in this EKG
elevations again inferior lead.
Inferior lead, yes, inferior lead MI, right? ST segment elevation MI in the inferior lead. Drug-eluting stent is placed in the proximal right coronary artery. He is transferred to the coronary care unit. On physical exam, blood pressure is 80/50, pulse is 120, respiratory rate is 20, oxygen saturation is 94, patient breathing ambient air, S3 is held, there is no pericardial rap, central venous pressure is elevated, the lungs are clear to auscultation. Which of the following is most appropriate treatment? Intra-aortic balloon pump, intravenous dobutamine, IV 0.9% saline, oral metoprolol.
B, sir.
Huh?
B.
IV dobutamine. Okay, what else? Anything else? Remember, BP is 80/50. እና inferior MI ምን አይነት ነው የሚያመጣው? Which part of the heart is affected? Right ventricle or left ventricle? With right coronary I mean inferior well MI ስንል which vessel ነው? Right coronary artery ነው አይደል blocked የሚሆነው to give you inferior well MI. So most probably you are dealing with right ventricular failure, right? So and the patient is hypotensive. So what shall we do? And right-sided heart failure is volume dependent. Central venous pressure elevated ነው ምንድነው? ይሄ ሁሉ የሚያሳያችሁ በዚህ right ventricular failure መኖሩ ነው because the lungs are clear left sided failure አለመሆኑን የምታውቁት pulmonary congestion የለም lungs are clear ይላል What is the answer guys?
People are saying C, sir, on the group chat.
Yeah, they are right. They are right. It is C. So a patient with an inferior myocardial infarction with right ventricular involvement and hypotension should receive IV fluids. All right. All right, guys. You know I have to be ready. I have to leave because I told you multiple times. And now I'm so happy and excited to start this project. We have started it this way. I don't know whether you liked it or not. Give me a feedback. ባጭሩ ቶሎ ቶሎ አንድ ሁለት ሰዎች what did you feel? Is this something new to you guys? Something similar to your experience in the past? Are you happy about it? Shall we continue it the same way? Is it beneficial? Do you think this is beneficial and all that? Huh? Can you say something?
Sir, this was very stimulating and it was really exciting and it was really cool to see different people's perspectives and your professional input was amazing, sir. Thank you.
Thank you so much. ቀጥሉ ጓዶች ውዳሴ ከንቱ ብቻ ሳይሆን ክሪቲክም ከሆነ ክሪቲሳይዝ አድርጉ ይቀጥል በዚሁ እንሳተፋለን እኛም በደንብ እየተሳተፍ የበለጠ እናበለጽገዋለን የምትሉ ከሆነ በዚሁ እንገፋለን አንድ ሁለት ሰው ሐሳብ ጨምሩና እኔም ልሂድ
This was a very good session. Honestly, it's like comprehensive management ድረስ ስለነበረ now like the ruling out differential diagnosis was very helpful as well. One input I would add is differential diagnosis ላይ maybe እኛ ከዘረዘርን በኋላ መጨረሻ ላይ on how to go by it የሚለውን ነገር ከአንተ perspectiveም like እንዴት እንደምትይዘው ወይም how do you think about it የሚለውን ብትነግረን would be nice.
This is how I think about it. Just the way we did it. So like, you know, when I encounter a patient with a certain differential diagnosis, I would have a list of pathologies in my head. And then like, you know, of course, I'm not going to waste my time listing all the nonsense, but like, you know, in my head, there is this exercise. Shall I keep costochondritis? No, it's out. Shall I keep P? No, it's out. Instantaneously, my head is processing that way. Shall I keep esophageal rupture? No, when it tells me there is no vomiting, it's out. I'm not going to list them in my differential diagnosis list. Just for academic reason, for ease and clarification of our discussion, I have to list out 20 or 15 differential diagnoses. This is just to help you understand. Otherwise, this is a way I think. Chest pain, what could it be? Could it be P? Could it be aortic dissection? Could it be rupture? Could it be pleurisy? Could it be pneumonia? Could it be something? All this is in my head. It just comes instantaneously. But when I take history, when I do physical examination, I kick out most of the stuff. And like, you know, by the time I'm done with my physical examination, I made the diagnosis of a STEMI or an STEMI or unstable angina. It took 2 hours because I have to explain things. I have to moderate. I have to ask the questions. But within minutes, I will diagnose a STEMI or an STEMI. But the process I use is the process we just used right now. And my rationale would be the same thing. You got it?
Yes, thank you.
Yeah, so like, you know, when you start as a medical student, you may come up with 10, 15 differential diagnoses, and people would wonder, why are you saying pancreatitis? Because at this stage, I will never consider pancreatitis as a differential diagnosis. Or I wouldn't mention something which I think is remote. Because like, you know, when I discuss with a cardiologist, I'll tell him, I think this is an STEMI or a STEMI. That's it. I'm not going to tell him this could be PE. I'm not going to tell him this is going to be esophageal rupture. I'm not going to tell him this could be aortic rupture. This is for an academic reason that we have to list all these things and then, you know, narrow down the differential diagnosis. And this is the way, this is the skill. This is how you develop that skill of telling a differential diagnosis within minutes. You know, you are beginners, that's why you have to do it this way. And I was taught this way, by the way, and I was encouraged to think this way when I was a medical student like you guys. Right now, I don't have to list down all these differential diagnoses. I can tell you, if you tell me, oh, this is a patient with chest pain, retrosternal, radiating, also, most probably this is angina, do EKG, do troponin, do chest x-ray, that's it. Tell me the results, that's it. Because like, you know, the nurse at night could call me, Dr. FSH, I have a patient, all of a sudden patient is complaining of chest pain, pressure, like it's radiating to his shoulder. I tell her on the phone, okay, get EKG, 12 lead EKG right now, get chest x-ray stat and do troponin, tell me with the results. That's it. You know, I'm not going to tell her, oh, do the coronary angio, blah, 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 blah. No, this is how I think. And the reason why I think like this and I am so quick to make a decision is because I am attending right now and I pass through a lot of process to reach at this level. But I have to teach you how you should do it as a medical student. And then eventually you develop this skill and you know you'll reach this level. You got my point? This is how I approach it in my head. You got my point, guys? Did I answer my question, your question? Hello, hello, hello. All right, so thank you guys. I appreciate your presence. Next time, try to bring more people, if possible, from different schools. Try to engage more, and we will try to have some incentives and all that. Then, you know, it will be more productive. It will help you more. I love you guys. Bye-bye. Thank you for coming. And if you have feedback, if you have a feedback, send that feedback to Gamachu, to Betty, to Zex and other there are about 16 team members from different schools. Just, you know, share your idea and everything. We'll implement more and more improvement along the way. Zex, I'll talk to you later on. Okay, I'm rushing. Have a great night.
No
Bye-bye.
worries.
Bye-bye, guys. Okay, I'm rushing. I'm
Thank
sorry.
you, Doctor. Thank you, everyone.
All right. All right. Thank you. Thank you, guys. Bye-bye. I'll ask for feedbacks, Zex, okay? Actively ask for feedback. That's how we can improve. Okay, bye-bye. Can you end the meeting, sir?
Yes. Last thing I'd like to say is YouTube ላይ ታገኙታላችሁ record ስለተደረገ.
Okay. So will you have the recording or it's going to be in my end where we get
it's on your end, so if you could send it to me.
ስለዚህ በቃ እንዳለ ላፕቶፕን ሳላጠፋው ሄድና እንትን ሞዲፋይ አድርገን እንለጥፈዋለን ዩቲዩብ ላይ። ሰላም ሁኑ፣ በርቱ፣ ጎበዝ ሐኪሞች ሁኑ and that way you make me happy. Okay, bye bye.